So today is our first recording in person together, and we're going to be talking through some of the basics about TRT and what might make people interested in checking their testosterone levels and some signs and symptoms that might make people believe that they potentially had an issue in that area. So I'm Dr. Angela Servis and we're from Eden Clinic.
And I'm Felix, I'm Advanced Clinical Practitioner with Eden Clinic also.
Tell me, in your experience working in the field of men's health, what are the really common symptoms that people come to you with that they're sort of concerning them?
Yeah, so it's fairly similar for most guys. So your most common ones are, this is mentioned a lot, brain fog, increased fatigue, lack of recovery from exercise, inability to actually put on muscle tissue or lose body fat despite dietary habits, exercise. Sleep disturbance is quite common, sometimes anxiety, and then you've got other things along the lines of sort of the more sexual dysfunction side of things. So erectile dysfunction, lack of libido are probably the most common things we tend to see that get guys looking into this route when they've exhausted all other avenues. Yeah,
checking their levels. And I think often they might go and see their GP if they get pestered into it, and they'll go and see their GP and potentially be offered an SSRI or an antidepressant, which sometimes actually makes things worse. And I think that can be one of the things that by the time they actually certainly get into clinic and they're trying to, they may have found that they've got a low testosterone level on Medichecks or whatever. Actually, they're quite far down the line. They've had these symptoms for a long time.
Absolutely. And the biggest one about SSRIs is two of the symptoms that are commonly reported that actually get exacerbated or worsened, like you were mentioning, and that's sexual dysfunction and weight gain. A really common side effect of the most commonly used SSRI, which is sertraline, which is given out very readily by general practitioners, is weight gain. So it's really hard for these guys because they go in looking for a solution to a problem they probably don't yet know they have and get given the wrong course of treatment, which, with all due respect to general practitioners, I know you're a GP by background, it's a hard job. If you get something that mimics a depressive disorder so well, you see a swan, you call it a swan. It's and that's what leads them, and they're not giving these medications because they're trying to say this is what this is and it's definitely not what you think it is. It's because it looks like that symptom set. So it's all done with the best intentions, but often it's a misdiagnosis and therefore a mistreatment. And we often have cases where we've successfully managed to get guys to either wean down their antidepressant doses or come off them altogether because the initial root problem wasn't depression, it was low testosterone.
Yeah, and it's a shame really, because I do wonder what percentage of men of a certain age that are going in with depression, actually, if as part of the depression screening bloods, if testosterone levels were in among those.
I mean, imagine if testosterone or in an ideal world, a complete hormone panel was part of a TAT screen, because obviously common things are common. That's what they teach us in diagnostics, isn't it? And when you do a TAT screen, the main hormone you're thinking about is thyroid, and that is super important, especially in conjunction with testosterone deficiency. But when you do a TAT screen, for the viewers, that's tired all the time screen. So probably shouldn't speak in acronyms. So tired all the time screens are done very routinely and quite readily by general practitioners in the UK. But the only hormone they really look at is thyroid, which is probably the most common causative factor for a primary complaint of fatigue. But when you're factoring in the other symptoms that these guys present with, it would be great if the standardized TAT screen included testosterone, free testosterone, estradiol, prolactin, SHBG. It's something that I think definitely would be a move in the right direction to ensuring a more comprehensive screening to rule out other things.
And I think the difficulty with that is actually it's the next question. So if there were to be a testosterone deficiency found, actually the NHS isn't, as things stand at the moment, unfortunately ready for the fallout of that, and for knowing, we haven't really properly put in the forefront the British Society for Sexual Medicine guidelines, which actually gives you really good and comprehensive, quite straightforward guidance, but that hasn't really been pushed out onto the forefront. So that we can support those patients, and I think that's probably where one of the difficulties are. And that, alongside when you mentioned about doing tired all the time screens, but also diabetes, we know that there's a really high level of testosterone deficiency in people who develop type 2 diabetes. And it's not part of the standard.
No, yeah. So your
really
HbA1c testing, or your glycosylated hemoglobin A1c, which is a test of your the way your body deals with sugar over time, it's actually quite a good test, because it shows us not a snapshot in time like a standard blood sugar level that you might associate with someone pricking their finger and seeing what their blood sugar level is now. It tells us how your body is dealing with sugar over time, and that gives us an idea about insulin resistance as well. And you're right, it is really common to see a correlation between type 2 diabetes and testosterone deficiency. Now, that's a bit of a chicken and egg scenario, because did the type 2 diabetes lead to weight gain, which then increased aromatization, so the conversion of testosterone to estradiol, and that caused the low testosterone level? Or was it low testosterone and low mood that decreased their motivation to do things in life, and therefore changed their way they seek dopamine by eating things that give you that quick dopamine hit, like chocolate, sweet things, and that then leads to the weight gain that then shows the low testosterone. So it's a hard one, that one, and there's definitely a correlation, but trying to say which one is causative is very difficult. But I'm of the opinion that if you are presented with a gentleman who has all the listed symptoms of testosterone deficiency, but they are overweight, and they do show in their blood markers, so an initial comprehensive panel including HbA1c, and then a confirmatory test about 4 weeks later of their hormones still being low, do you tell them, no, you've just got to lose weight first and I think your testosterone will come up? Or do you give them TRT so that their motivation comes up to lose that weight, and also increase lipolysis through fat mobilization through, once you increase someone's testosterone level, that will increase their hormone-sensitive lipase synthesis, which is a key enzyme in the hormonal process of breaking down fats. So we all remember back to our sort of A-level biology, the fatty acid chains with all the tails and things, and HSL is a part of that. In amongst the CAMP process, the adenosine monophosphate process, which is that secondary messenger in our cells to increase lipolysis or fat breakdown. These patients, they come under a category called MOSH, which is quite easy to remember, or male obesity secondary hypogonadism, which in and of itself is a categorization of testosterone deficiency. So I think, you get this difficulty for primary care physicians where they're presented with that scenario, and the way that they think is safer or is maybe quicker to deal with at that point in time is to ask them to lose weight. But that's so hard for these guys, because the reason they've gone there in the first place is because they're so fatigued.
And they're symptomatic with it. And I think in the same way, they wouldn't tell the person who was struggling with obesity to go away and lose weight before they'll treat their hypertension.
Exactly. Yeah.
And I think that actually comparing that is actually quite a reasonable and realistic thing to do. And I think when people come to us as male hormone replacement specialists, actually, I think it is quite reasonable to assume that they have already come having tried to lose weight and tried to address some of those lifestyle factors. But that also to be said that, actually being realistic with the patient to say, this isn't going to cure everything.
Yeah, it's not a panacea, as per our friend Dave Lee says. It's not the cure-all. What it does do is allow you to have the things in place to allow you to do what you need to do to reverse those other negative consequences of the symptoms you had from your testosterone deficiency, for sure.
Yeah, absolutely. And I think that's where it becomes... I think sometimes some of our patients can come on board and start taking testosterone replacement therapy, and it gives them so much more additional bandwidth to be able to manage some of the other symptoms and to be able to manage some of the other sort of lifestyle factors that are within their control, that actually they see improvements across the board. And in some ways it can almost make it feel like the testosterone is doing everything, and it's not. It's just giving them more capacity to manage the other elements.
I think that's a really key point you touch on, because a large proportion of testosterone deficiency symptoms are psychological, but they have a correlative relationship with the actual biophysiological deficiency of that hormone, and it's easy to think that it's the testosterone that's made everything better, when actually it's just allowed you to, and I think that's key, have the emotional bandwidth to be able to say, actually I can deal with this, and what I'm going to do about this problem today is X. and that in and of itself isn't easy either. Sometimes you need help, like so you can use things like cognitive behavioral therapy is very effective. Mindfulness. I know you're a big fan of journaling. That's writing down what your thoughts are, not just the negative but the positive also, and really being appreciative of what is going well, so that we don't fall into that trap that's so easy, especially when you've got low testosterone, of focusing on the negative things. Absolutely. And life coaching can help. So lifestyle coaches, having someone to help you plan your exercise regime, because like you said, the fat's not going to melt off you if you start on testosterone therapy and get to healthy levels. It's just going to have a minimal impact on lipolysis, like we described before, from a hormonal perspective. But the biggest factor will be your nutrition. So you've got to eat well and eat right and in the right quantities. That one's a big one. Portion control is something we're terrible at as human beings. And do the exercise. Like testosterone won't make you fit and healthy overnight. It's a long game, and it's something that you're hopefully going to be on long term under the guidance of an experienced practitioner who can help you navigate that side of things, so that you don't have to worry about it, because then you can just concentrate on doing the things you need to do, and the testosterone can allow you to do that. Yeah,
absolutely. And I think actually it can be quite as you know, we've discussed, I think a lot of the time when guys actually do get to the clinic and get to have their symptoms recognized, and you can say, these are all, you can explain these by, but actually taking that time to say, okay, here we are, we're about to start something that will give you that toolkit. And I always use that same analogy. I'm giving you the toolkit. If you don't take the tools out of the box, it's not going to do anything. But actually creating that structure and having that real conscious, you're about to step over this line and then it's over to you. And it's just kind of, it's also recognizing what is and isn't within the remit of your TRT.
Yes, I think we that's an amusing one for both of us, isn't it? And I'm sure anybody who's worked in this field can understand this. So you get a lot of patient experiences where they think that they're doing enough and that the TRT will allow them to do slightly less. But it's like you said, I love that analogy. You can have the toolbox and they're all in there, but if you don't open it, then you can't use them. And that sort of it's not in all cases, but in some cases that patient perception of it doing the medication doing for them what they need, rather than you doing what you can with the medication, is a mindset that really needs to be flipped. Because I like what you said, you bring them to a threshold. It's like you're about to step into this, and then the commitment is very much over to the patient. And we're here to help with ensuring that their medication protocols are done correctly and safely. But we can't do the work for the patient. That is something that as a patient on TRT, you have to take full responsibility for and commit to as well.
Yeah, absolutely.